Nick is a consultant intensivist and is the lead for the ECMO program at Guy's St Thomas's, and is going to talk to us about ECMO. Thank you very much.
Thank you very much, Luigi. It's a pleasure to be here today. I know that some of you are from St Thomas's, and so some of what I say will be very familiar. I'm going to take extracorporeal support from fairly basics and then show you some cases. I'm delighted to answer some questions as we go along. And I promise to be done by 4:30 to bring you back into time. I have no personal conflicts, although I have some funding for other things. We're all aware of this. This is the old ARDS definition back in the 90s. In order to try to stimulate research into these patients with severe hypoxic respiratory failure. The truth is that we all know that this patient on 100% oxygen with a PF ratio of 4, terrible pulmonary compliance, is nowhere near the same as this patient. We know that the patient on the left of the screen is highly likely to die within the next few hours unless we do something. And I know this morning you've talked about some of the somethings that can be done, and we'll talk about one of the different ones. The recognition of this led to the definition, the Berlin definition, which I'm sure we've already discussed today. And the group that we're particularly focused on this afternoon is patients with a PF ratio of less than 100 or 13 kilopascals. We know overall that over time, particularly with the rollout of lung protective ventilatory strategies, ARDS outcomes, even for the most severely ill, are improving, but they are still very, very high, with significant mortalities, 40-45%. And in the UK, if we look at ICNARC data, particularly, and data from trials like Oscar, even having a PF ratio of less than 200, so less than 20, about 150, gives you a much higher risk of death, about 40% in the UK, which is not so good. And that's all despite protective ventilation with mortality rates of 50% or more in the cohort that we think of as potentially suitable for ECMO. Conventional management strategies, of course, we're all thoroughly aware of. The aim being lower tidal ventilation, lower pressures. And we don't really know what the optimal tidal ventilation is. We don't know what the optimal plateau is. There's a suggestion that maybe 25. 25 might be better than 30, 20 might be better than 25, 15 might be, of course, better than 20, none might be the best thing of all. We don't really know where that all sets. We know some things are more harmful. We know driving pressure, the higher you get on the driving pressure, even with maintained volumes in the 6 to 8 ml per kilo range, seems to increase mortality. And we know that ventilation, even for a brief period of time, can lead to this, which is significant ventilator-induced lung injury with gross barrier trauma with pneumothoraces and cystic changes there in the anterior lung. And this patient had been ventilated for 3 days. She's 25 years old. Not particularly aggressively, third plateau pressures of 35, but nonetheless, she already had very significant barrier trauma. So we don't really know what is protective. We don't know how low we should be going. Should we be ventilating at all? Maybe, maybe not. We do know, however, that if we try and bring down tidal ventilation, and in this case, this was a nice little study by Taragni's group, they brought it down to 4 mils per kilo, and you could see a rapid rise that occurred in CO2, and it was only through the addition of extracorporeal support that they could maintain a sensible pH and CO2 clearance. So it may be that CO2 removal and extracorporeal support as an adjunct to standard ventilatory practices or ultra-low tidal ventilation may well be something of the future, and that's something that's going to be tested in a number of trials coming forward. We also know that if we do drop the tidal ventilation, we do get significant de-recruitment. We get a loss of FRC, and so we need to manage the oxygenation, manage the PEEP. It's not necessarily just as simple as turning down the ventilator and starting some CO2 removal. We need to understand these strategies much better. If we do have a patient with refractory hypoxemia, we know that we have multiple different options, many of which you've discussed today. We don't really know what is the ultimate the ultimate strategy to look after our patients. And in all honesty, there's probably not one strategy that suits everyone. We probably need to have a bespoke approach to the patient with severe respiratory failure. People talk about permissive hypoxemia. And we know that in the womb, Mount Everest, grey diving seals, we all have about the same PO2, about 3 kilopascals, give or take a little bit. And as far as we can tell, people are just fine. So why bother with giving oxygen at all? Why not just let the SAT sit at 60% or 50% for the duration of the trip that somebody is this sick for? Well, we don't necessarily understand all of the problems related to profound hypoxemia, and this is the healthy brain, or the not so healthy brain, of people who've walked up Mount Everest and come back down. And we know that in the brains of patients with significant hypoxemia as adults, that we do see structural changes, particularly within the temporal cortices and the optic cortices. We don't know where we should be targeting PO2. We don't know whether 80 is better than 90 or 90 is better than 80 in terms of percent saturation. We do know if we get low enough that we will cause harm, and we are looking at the moment in patients with severe respiratory failure and profound hypoxemia in the setting often of sepsis, what their MRIs are like. And we do know that they have significant neuropsychological sequelae afterwards and significant problems with structural changes within their brain, which will hopefully be a publication coming to you in the near future. People also talk about permissive hypercapnoea. Again, I'd put it to you, we don't really know how low or high CO2 should be allowed to set. We know it's a balance, and probably in any given patient, it's not the exact CO2 or the exact pH, it's the impact of it. And we know that there are pros and cons. We know that if your CO2 rises, you do get improvements in VQ matching, improved cardiac output, improved cerebral blood flow. But as it reaches the tipping point, we get just that little bit further, a little bit higher, a little bit lower in the pH. We reduce myocardial contractility. We cause hypotension through decreasing systemic vascular resistance. We go from increasing cerebral blood flow to causing narcosis. And on any individual patient, we need to think about what is the net physiological effect on that patient. Is that patient 21 years old on no vasopressors with a pH of 7.19? Do we really need to rush in and change it? Are they 65 years old on multiple vasopressors with septic cardiomyopathy and severe acute renal failure? Do we really want them sitting there with a pH of 7.25 when they're on 1.5 mics of noradrenaline? I don't know. But these are the things that we need to think about when we're banding around the terms permissive hypoxemia and permissive hypercapnia. We don't really know what we should be doing. We know that neuromuscular blockade is helpful. Beta agonists are not. Nitric oxide improves your oxygenation, doesn't improve your survival, which is relatively important to most patients and is at vast expense. Steroids, what a debate. And I'm sure it will continue going on for some time yet, whether it's early or late or targeted or non-targeted. My personal belief is that mixed in within the ARDS literature is a whole group of patients who do have a steroid-responsive lung disease. They probably have interstitial lung disease. And we've had a number of patients, probably 15% of our ECMO cohort, have a previously undiagnosed severe acute interstitial lung disease. And those who respond to steroids tend to fall into that group, and they tend to do incredibly well as a group if they respond to steroids. Prone positioning, we should be definitely thinking about and definitely doing unless we've got a clear contraindication. But remember, this is in the group with a PF ratio of less than 150, less than 20 kilopascals. This is not as sick as we're talking about for the ECMO cohort. This is much earlier. And how many of you here routinely prone people when they hit 60% oxygen as inspired? No one. But that's what the study was. That's where they were looking at. That was their target population, 60% or more. So, and that's where the survival advantage is. So we don't necessarily pay a lot of attention to the literature or implement it in the way that the original authors did. Oscillation. Who here still does oscillation? So oscillation has never had a positive study in adults. Pediatrics, completely different kettle of fish. Never had a clear positive study in adults. And we've got OSCAR, the UK study, showing no potential benefit. We've got the OSCILLATE study from North America showing probable harm. And again, in patients with a PF ratio less than 150 in both groups. What's really interesting, I think, is that in the OSCAR study, we couldn't get in the UK below 8 mils per kilo for our conventional limb for best practice, routine practice, conventional ventilation, which again I think is fascinating when we think of UK ventilatory practice, how in a randomised controlled trial of patients that we should be really focusing on and worrying about their ventilation, we still can't get below 8 mils per kilo, which is interesting. The North Americans did manage to do that. So the authors of the Berlin definition came up with this rough schema, looking at low tidal volume ventilation for all, rising PEEP, neuromuscular blockade, prone position, maybe CO2 removal, ECMO. We'll go through the evidence for that, limited though it is. Personally, I don't really think we should be thinking about oscillation. I don't think there's any evidence of benefit. I think there is certainly evidence of harm. I think if we're going to be doing it, it should be done in the construct of a randomised control trial. Would be my view. Before we think about ECMO, we just need to go back to some very basic physiological principles. As you all know, oxygen is carried in blood attached to hemoglobin. And as a result of that, the oxygenation in the blood is very much dependent upon the shunt. And if we think of patients with severe lung injury, clearly their shunt rises from 10% to 50%. The carriage of oxygen in the blood is why we can't increase their oxygen capacity or carriage, actual carriage in the blood, because we can't increase the amount attached to hemoglobin because of the shunt fraction. The same is true on ECMO. And we need to bear that in mind when we think about how we manipulate patients' physiology and oxygenation when they're on ECMO. On ECMO, in this case, if we're talking about vena-venous ECMO, we're taking, not quite accurately on my beautiful little picture, but from the venous side and returning to the venous side, some of the blood will run through our oxygenator. We can't capture it all. We are not providing total cardiac bypass. We don't tie off the right atrium and suck it out. We place a cannula into either the inferior vena cava, the superior vena cava, or both, and draw some of that blood through our oxygenator, and then it goes back into the venous side and mixes with the patient's venous blood, which means that we have an obligatory shunt. Now, if we have a patient who's got H1N1 and a cardiac output of 15 litres, and we have a pump which can run at 7 litres on a very good day and more usually at 6, there is no way we can get up to 100% of cardiac output. It's just not conceivable. So we have to have a shunt. We will never get the SATs much above 90% unless the heart isn't working very well, in which case in a low cardiac output environment, we do get much better matching because we can run at 5 litres versus 3 litres of blood flow through the heart. So systemic oxygenation on ECMO depends upon the shunt fraction, so the patient's cardiac output. It depends on how much blood we can get through here, through the machine, which in turn depends on the size of the cannulae, so we tend to choose fairly large cannulae. The FiO2 through the oxygenator, as well as, of course, how well it's working and how well the patient's lungs are working. CO2 carriage, however, as we all know, is carried predominantly as dissolved, 10% dissolved, 60% bicarbon, the rest is carbamino compounds. Which means that as we increase the, as we increase the sweep flow, as we increase the blood flow, we do get a small increase in CO2 clearance. I thought I had the sweep flow there as well. Anyway, mainly as we increase the sweep flow, which is the gas running past the oxygenator, so it's analogous to minute ventilation. That's where we see the most marked increase in CO2 removal from an ECMO circuit or any form of extracorporeal circuit. But naturally, we do get some change as we go up to higher blood flows. So predominantly, oxygen is dependent upon the blood flow coming through our device. CO2 clearance is predominantly dependent upon the sweep gas flow, which is the gas that we provide through the oxygenator, and it's that rate. So when we're looking at manipulating an ECMO circuit, these are the two key things we can change. If the patient is hypoxemic, we can increase the blood flow through the device up to a given point, and beyond that given point, say 6.5 litres in an adult, we need to start thinking about reducing the patient's cardiac output, whether that's through frank retardation of the cardiac output using beta blockade, or through manipulation of the oxygen consumption through temperature control, through paralysis, through sedation. CO2, however, depends very much upon the sweep gas going through the circuit, as well as the CO2, as well as the oxygenation, the oxygenator function. If we think about the broad spectrum of extracorporeal devices, then we can really think about them depending on the blood flow that they generate. So if you want renal support, you can clear much of the body's toxins from a couple of 100 mils per minute of blood flow very easily. Clear urea, clear creatinine, clear all the middle molecules. If you're looking at ECMO, so total extracorporeal support for the respiratory system, you need upwards of 5 litres of blood flow in order to provide oxygenation. You can then remove the CO2 from that highly oxygenated blood relatively easily using a high sweep flow. But for most patients on ECMO, if they're not too septic, we're looking at roughly 1:1. So if we're looking at a litre of blood flow, roughly a litre of sweep flow. So a litre of gas per litre of blood flow. Because of the difference in CO2 clearance from the bloodstream, we can also use partial extracorporeal support using the principle that we can clear a bit of CO2, up to 25, 30, maybe 40% on a good day, with a relatively low blood flow. This means that we can look at different devices which have different complications, different impact upon the blood, and different indications for extracorporeal support. The first one that in the modern era that came out looking at a low flow device was arteriovenous CO2 removal, or the Novalung device, and I'm sure many of you have used it. Yeah. So that needed 750 mils a litre of blood flow, and you could run up to 8 litres a minute through the gas exchange membrane and clear a reasonable amount of CO2. And it did what it said on the can, which was it brought the CO2 down in the blood. There have not been good studies looking at outcomes in terms of mortality benefit, and we found in our practice that this side, being the arterial side, we had a lot of arterial injury, even with the 15 French cannula. More recently, there's been the development of a new range of different devices using dual lumen cannulae, and these are the current ones available, although not all of them in the UK. They use dual lumen cannulae, a bit bigger than a Vascaf, 15, 16, up to 19 French. All are pumped systems and all remove CO2 adequately from the bloodstream at between 500 mils and a litre. So certainly it opens the idea that we could use it potentially as an adjunct to mechanical ventilation. However, thinking about a bit more at the higher end, the larger volume devices, this is conceptually what an ECMO circuit looks like, so in the modern era. So we can have either a single dual lumen cannula or multiple single cannulae. I prefer the single lumen cannulae for ease of insertion. We drain blood from the venous side, run it through a pump, through the membrane oxygenator, and then back in. And you can see in this, we get the mixing of the blood that bypasses, mixes in the right ventricle, and what more or less the pulmonary artery is exposed to, the radial artery is exposed to. We do have some problems with recirculation, and that reduces the efficiency of an ECMO circuit, where the oxygenated blood just goes round and round and round. But nonetheless, despite that, we can manage patients. And this is one of the types of circuit. This is the older style of circuit, but the advantage of this is you can see all the parts. See the tubing coming down here full of blood from the patient to the centrifugal pump, runs up through the oxygenator. You can see the gas supply is just there, and that attaches all the way down to our blender there, where we can select the FiO2 as well as the rate. This device up here controls the rate of blood flow and hence the oxygenation of the patient. and then it runs back into the patient. We need to control the temperature of the patient using a heat-cooler device, much the same way you do on renal replacement therapy, only clearly we've got nearly a litre of circulating volume out of the patient at any given point. And then there's a variety of different types of monitoring depending on exactly which circuit you have. ECMO has one positive study to support its use. There were studies in the 70s and in the 90s, all of which were negative. They were negative with very high complication rates and very significant mortalities in both groups. The first ECMO study had 90% mortality in both limbs. This was the CSER study, which is the only positive study that we've got in terms of a prospective randomised control trial, and it isn't really a randomised control trial of ECMO versus not ECMO. It's really a trial set up by the HTA and the UK Commissioners for Healthcare, specialists. They were then known as the Specialist Commissioners, now in NHS England. And it was designed to explore the concept of severe respiratory failure centres. Was transferring patients who were this sick to a specialist centre where you could potentially get ECMO, and 80% of those who did get ECMO, in the ECMO limb got ECMO, was that a better outcome for society or the patients than if they didn't? And so, although this study has some problems if you're interpreting it purely as ECMO versus not ECMO, from the UK Commissioner's viewpoint, this was viewed as an incredibly positive study because it showed them the way that they could see a UK health system developing. And I think it's important as we move forward and think about some of the trials that will be coming out in the next few years, that this is going to be the same model of trial, because this is the model of trial that the HTA wants to pay for. Not whether it's scientifically the perfect trial, but whether it works in our system of care. And particularly this sort of hub and spoke approach is something that's going to be explored in a number of trials that are coming up. The thing that really pushed ECMO, of course, was the swine flu. And this was the bed occupancy in 9-10 and in 10-11. And it's worth bearing in mind we have 1,600 adult ICU beds in the country. So this 851 simultaneous beds filled with young people with flu caused a bit of stress in the system. Flu, of course, it hit Australia first, and Australia has always had a hub and spoke model of healthcare. They have to. They've got a hub and spoke model of living. And they've always had a very good retrieval service, getting patients from smaller places into larger places. And they've always had an expectation from places that they will be sent, both within the hospital system, but also, most importantly, within the families. They expect, why aren't we going to Sydney? Thank you very much. Well, it's only a 2,000-kilometre trip. We've got to wait till the plane turns up. So that system was in place, and the large places that accepted these patients also happened to do ECMO. And this was not a randomised trial. This was purely clinical practice. And what they did was they took the patients who got referred into ECMO-capable centres with swine flu. Roughly a third got ECMO, 2/3 didn't. They were managed conventionally. But 80% of the ECMO group survived, which was better survival than CSER and the best survival from any ECMO series that has ever been reported. Well, was reported to date. And it's worth bearing in mind that overall in international practice, ECMO survival to survival leaving the ECMO institution is 55%. That's the ELSO database, which is the registry for all ECMO. It's voluntary, except in the UK. In the UK, how did we fare? Well, we had a similar outcome for patients who went to ECMO-capable centres, which was about an 80% survival. This was not prospective. This was a retrospective analysis with a propensity match series. And in our ICUs, with an average of age of 25 to 30, and you were matched in every way to those who got referred to ECMO, if you didn't get referred, you had a 50% survival. Make of that what you will. But I think that's worrying. We've seen, as a result of CSER, swine flu, greater experience with ECMO, greater exposure to ECMO, we've seen a rapid increase in the number of cases that are being done internationally. And again, we're still, at the moment, still hanging very much off the one positive-ish study. In the UK, we've, of course, developed the 5 severe respiratory failure centres, and I'm sure you've all referred patients to those centres, and we look after this patch of England down here. It is an English service. The Wales, Scotland and Northern Ireland do not commission an ECMO service at this point. And it's a little bit ad hoc if you get sick in those areas, if you wish to access ECMO. But people will always accept patients from Scotland, Wales and Northern Ireland. London is split up more or less along the line of the Thames, with Papworth taking the northeast corner. And the indications are acute, severe, potentially reversible or believed to be reversible respiratory failure, who are sick enough with a high Murray score, relatively short duration ventilation without life-limiting comorbidity. And we've seen a lot of patients over the last few years. This is the growth for us, and this is ECMO days, not patient numbers. But the patient number graph is exactly the same, because the average or the median run across all these is about 14 days. The commissioning started in 2011 in December. So this was the 11, 12, 12, 13, 13, 14, and this little aqua one, 14, 15. So it's been steadily growing in terms of the number of patients that have been referred to our service for consideration of ECMO and received ECMO. And this is the same picture that we've seen across England within the other 4 centres. What are the sorts of patients that are more likely to survive? Well, younger patients, so not dissimilar to the rest of critical care. Plumper patients always do well. Immunocompromised and sicker don't do so well. And they're the bits that you can't really fix, because they're the bits that the patient sort of comes in with. What concerns me most, this was a series, this was a retrospective analysis from French data, is that the things that we can fix, so if you're not proned, if you're ventilated for a long time, if you've had inadequate PEEP and high plateau pressures, and this is all what you would consider to be poor ventilatory practice, they're all associated with a significant increase in mortality. And in this, bearing in mind 6 of those points were for bad ventilation. So you can be 21 with flu, which is eminently reversible, and you can still have a 50%, 50-60% mortality just from poor ventilation. So it's very important to look at the way we're ventilating patients. There have been other scores which tried to do a more complex analysis. And in this case, the higher the score, the better. And it recorded things like, particularly, where is it, asthma, I think it's about 11 points. So saying virtually no asthmatic should ever be allowed to die. And 92% survival. And they were very similar groups. So poor ventilation counts against you, being sicker counts against you, having comorbidities and being older counts against you, being plump is good for you. Other groups of patients that are slowly, used to be considered contraindicated to ECMO, but are slowly coming to the fore, patients with pulmonary hemorrhage. We're seeing more patients with primary pulmonary hemorrhage, particularly the anchor-associated vasculitides, who do very, very well if they get access to ECMO. Pregnancy is a technical challenge on ECMO, but should certainly not preclude someone from receiving ECMO, whether the patient still has a fetus in utero or out of utero. It does predispose them to a slightly different disease spectrum, and it adds to the complexity, but nonetheless, we can and should be able to manage pregnant young ladies who are pregnant. Obesity used to be considered a contraindication to ECMO, and the truth is they do better. The key problem, the only real problem, is that patients who are very, very, very large are very, very, very difficult to cannulate. It's just like it's very difficult to put a central line in when your central line is 31 French. It's very tricky to get it into them just because of their sheer size. And I would defer to my nursing colleagues, but they look awfully hard to nurse. Very, very difficult. HIV also used to be considered a contraindication to extracorporeal support, but there's reversible factors in HIV and irreversible. Clearly, if you've got Kaposi's sarcoma of the lung, you are not going to get better, and you probably shouldn't be receiving ECMO. If you've got simply PJP, that group of patients does incredibly well on ECMO and probably far better than they do on conventional ventilation because we don't see the same pulmonary trauma. Haematological malignancy, however, consistently do very poorly. And there have been an occasional group of patients where they've managed to find a few survivors. In our hands, we've tried a number of patients with haematological malignancy, always the compelling ones. But he's 21, he's got lymphoma, he's had his treatment, we think it's cured. Yeah. Only one of them, and in about a series of about 8 now, only one of them has survived, and that was an older patient with burnt out CML. Every other patient has died. They've survived ECMO. Some of them survived ICU, but they're all dead within 6 months, every last one of them. And it's probably a marker of their immune system, the underlying haematological malignancy. And in adults in the ELSO database, it's less than 5%, so not the ideal patient to consider. Let's go forwards. What do we do when we get them onto ECMO? Well, in terms of management, it's exactly the same, up to a point, as everything else. We protectively ventilate. And when we think about protectively ventilating, often we're down to 0 mils per kilo, or 1 mil per kilo tidal ventilation. We're often at tracheal or dead space ventilation. You can see here this patient has some air in his trachea, or her trachea, it's difficult to know, but not much else. We do need a huge amount of respiratory physiotherapy, a lot of bronchoscopy, mucolytics, just to try and clear the huge secretion burden. Hemodynamic management is different. As I mentioned earlier, we do need to think more around matching ECMO flow to cardiac output. So we'll often use beta blockers, even in patients who are overwhelmingly septic, in order to promote some oxygenation. One of the things that's fascinated me is the number of patients who are on 1.5 mics per kilo per minute of noradrenaline when we go and pick them up, and their right ventricle is just buckling under the strain of dealing with their pulmonary circulation. I have a pH of 7.0, 6.9. And we put them onto VV ECMO. And traditionally, these patients, they thought, well, we have to get them onto VA ECMO, so veno-arterial ECMO, because their right heart is packing it in. For some of those patients, that's the right answer to go on to VA ECMO, and I'll show you a case of that last thing. But for many of these patients, as soon as we clear the CO2, control the pH, turn down the ventilatory pressures, the right heart responds beautifully. The noradrenaline melts away. And it's certainly more common than not to have patients who are on a substantial amount of noradrenaline when we place them onto ECMO to maintain barely a map of 55, 60 and mottled, horribly shut down extremities, just to get them onto VV ECMO and see the change in their circulation that decarboxylation and restoration of normal pH gives you. And you're often down within half an hour to 0.1, 0.2 mics. Not in all patients, but in many patients. So I do think we need to think very carefully about how our ventilatory strategies are impacting upon our right heart. We have a diagnostic pathway that we follow. And this is some example of our recruitment CT, CPAP 5, CPAP 40, in a patient who did not recruit, and in a patient who did recruit. And although you wouldn't want the patient to remain on CPAP 40, it certainly gives us a guide to subsequent ventilatory strategies. I'm going to whiz through some of these. This is ultra-low tidal ventilation, 40 mils. ECMO does allow you to do some other things that you can't do with these very, very sick patients. It allows you to get them up and mobilize them. It allows you to think about their psychological engagement, about how you're going to manage them, how you're going to look after them, how you're going to keep them engaged in the process. Play games on the Wii You can get them out and about outside. You can, if this works, get them up and walking around the room even when they've got no native respiratory function. So you can do a lot of things that you cannot do with high-intensity conventional ventilatory strategies. It's almost easier in some ways to do these things with our sickest than our moderately sick. ECMO is not without complications, be it bleeding, clotting, respiratory. Ultimately, lungs, when left alone, will heal. And our survival depends very much upon what is wrong with the patient. Bearing in mind, we think everybody should have a reversible pathology. Those that truly do have a more than 90% survival. Those where we get the diagnosis wrong have a very poor survival. But overall, our 6-month leaving hospital, back at home survival is 75%. I'll just show a couple of cases if you want. Yeah. I know we're very pushed for time, as am I. An asthmatic, high CO2, low pH, terrible chest X-ray, onto ECMO, had a bit of flu, 21 years old, shouldn't necessarily be allowed to die. And that was about 3 days later, actually. She got better incredibly quickly. And the asthmatics often do. Once they start plugging off and just dropping all those lung segments, once you've reached that point, then really rapid commencement of ECMO can be very much life-saving. Pulmonary hemorrhage in an 18-year-old, just finishing her G levels or whatever they're called in this country. Intubated, ventilated, not doing very well. Terrible chest X-ray. You can just see the pipes here coming through. She had an anchor-associated vasculitis. She'd been coughing up blood for a couple of weeks. And we were able to buy her the time for the immunosuppression to work without damaging the lungs further. And the acute ILDs with a very hot component, hyperinflammatory component, have done very, very well with us. And again, this was about 3 or 4 weeks later that she'd improved. Immunosuppressed patients are more of a struggle, and this poor young lady had CMV pneumonitis, primary CMV pneumonitis in pregnancy, thought related to a transfusion. And she had a lot of it. She had pneumonitis, enteritis, pancreatitis, hepatitis, and everything slowly got better. Although she remained profoundly neuromuscularly deconditioned. And I think for me, the main sequelae of patients with this severe respiratory failure are not pulmonary. They're neurological, particularly neuropsychiatric, and neuromuscular, with profound and ongoing weakness. We treated a CMV viral load, that's her pancreatitis up there. And she got better over time, and that's her CT slowly improving, and that was her off, although the pipes are still in, she was off sweep flow and off ventilatory support at that point, sitting on the side of the bed. This is an increasingly common scenario that we see. A young lady who came into us with overwhelming sepsis, short history beforehand, ventilated, very difficult to oxygenate, sorry there are millimeters of mercury, and profound shock. But she had a completely white CT and a heart that remembers that it used to pump. I mean, you don't need to, that's the left ventricle, left atrium, right ventricle, the aortic valve and mitral valve. And you don't need to be a cardiologist to see that this is a young lady who is in real trouble. She just had group A strep, very severe group A strep, but that's all she had. There was nothing else wrong with her that wasn't going to get better with a bit of IVIG and antibiotics in time. It took about 2 weeks for a chest X-ray to clear, and about 10 days for her cardiac function to normalise. And although it's a slightly different, it's not straight vena-venous ECMO, we add in arterial support as well to support the heart. we can certainly take the patients that we do take previously died. So most of our CTs of asthmatics are coronial CTs. This young lady should be dead. She shouldn't be back home with a family, which is where she is now. And so I think we do have in the UK a system which is now actually in truth the envy of the world, and everybody wants to copy the UK system because the outcomes of what is a biased and clinically driven service have been excellent for the patients that we offer ECMO to. And just to, before Phil talks to you about NIV failure, I'm going to talk to you about NIV failure as well from my viewpoint. And this is a patient who had, you'd recognise this exact patient. Not very well with background COPD, a life dedicated to the pursuit of inhalation of nicotine. At her best, with a stiff wind behind her, she could get 150 metres. This is the sort of patient that turns up in your emergency department and comes into our ICU on NIV every winter. She had a COPD rescue pack, she did all the usual things, got worse. She didn't really like her non-invasive ventilation. Had a respiratory rate of 50, pulling at the mask, punching the nurses, generally obstreperous and unhappy. She looked like she was about to have a respiratory arrest. So we used a low flow device. So this was 400, 500 mils of blood flow with a sweep flow of 10 litres per minute, and ran on a little bit of anticoagulation. Not her, because you can notice this is a bloke, but similar effect. Within about 15 minutes, was sitting up, not quite chatting, but went to sleep, and then later on that afternoon sat out of bed and had some dinner. Avoided intubation. And that was somebody that was not going to avoid intubation because we were about to intubate her. And the same with this chap. It was exactly the same situation. Punchy, obstreperous, aggressive, failing NIV patient. And although the evidence isn't there yet, I think this is the way that this is something that we're going to be seeing more of in the future. And I think over the next 5 years, we're going to be seeing more extracorporeal support happening. We're going to be seeing more of it in the local hospital. I think things like ECMO are almost certainly going to stay in a relatively small environment because there isn't a great patient load. But patients like this, on the other hand, with severe COPD, are patients that are going to be managed locally if the evidence pans out. And this was this particular patient's physiological trend. And so the respiratory rate here died from 50 down to below 30 and then remained so for the 72 hours. They were on ECMO. CO2 dropped, but it was mainly that drop in respiratory rate that almost certainly contributed to them not needing intubation. And this is only a part of our team. Thank you very much.